Okay, I hope you can see my slide.
Yes, sir.
Okay, so already I have discussed this, the definition of the pain. So how to take the history and what are the different components of taking the history? That is what we are going to talk today. We are not going to talk the other aspect in the clinical methods, but the clinical methods, how we are going to evaluate should be starting with a very, very good history. And after that, the different other steps to examine and to come to a conclusion of a provisional diagnosis and differential diagnosis. So in history, we are having the two important areas. One is the general history that is common for all kind of pain. Means suppose somebody is having the back pain, somebody is having the knee pain, somebody is having the shoulder pain. So general history is common for all kind of pain, all kind of regional pain. And the special history is you are going to ask some specific questions in the history that those specific questions are related to that particular area. That means if somebody is having the knee pain, some sets of questionnaires are there. If somebody is suffering from headache, some sets of questionnaires are there. So this is the specific. Somebody is having the headache, the questions are the knee pain, the questions are not the same. This is in your specific history. So general history. So these are the very important areas. Whenever you are taking the history, this should always be remembered. And history cannot be skipped. History, we have to give sufficient time. That is very, very important. So first part is here. You must be spending sufficient time. And I always tell these things. I have experience in my patients almost always that if we are talking nicely, sufficient time, when the patient will be exiting from your chamber, from your clinic, patient will be telling my 50% pain has reduced. Now this should be your time. So sufficient time, normally it should take at least half an hour, at least preferably 1 hour to complete the history taking in and examination together in a new patient. In an old patient which is already known, the time might be less, but sufficient time, at least half an hour to evaluate a patient suffering from pain. You cannot, there is no shortcut. Then is in history taking, what is important is your careful listening. You need not be, asking too many questions. You need not be interfering too much. You just listen. If you are basically listening, what happens? The pain is associated with what? Sensory and emotional experience. Let the emotions are expressed. Let the emotions are released. So this is one of the very important. By just careful listening, you can take care of your patient's pain. So just be a very good listener. Then is your empathy, not sympathy. It should not be said. Now you must be knowing the difference between the empathy and sympathy. Sympathy means you are, telling, okay, oh, you are having this, I am feeling so sorry. It's not like that. It's empathy. Means you are together with the patient. You are telling that whatever is there, you might be having chronic pain. Sometimes it is not curable, but don't feel depressed. I am with you. I'm with you in the process of your fighting with the pain or fighting with the disease process. So have an empathetic attitude. Be with the patient. Trust development. That is also very important. You have to be very good listeners. Always keep eye contact, and don't do another very important things. You're talking with the patient. Sometimes WhatsApp message is there. You're looking at the WhatsApp and never do that. And if we are becoming inattentive, patient by looking at your face, patient can understand. Many times what happens, some important things is going on in your mind. You're just listening, but not really listening. Patient can understand whether you are attentively listening or not. And that is going to develop the trust. Unless the trust is developed, patient is not going to express his or her, the inner feelings. He's not going to tell you. So this development of the trust, and again, key point is your careful listening. You just give time, listen carefully, attentively, start to be with them, and ultimately develop the trust. And only when you should be, when and how to interfere. Only sometimes, they goes irrelevantly to the other areas. Only then you can interfere, but try to interfere as minimal as possible. And sometimes we have to understand that what is the effect of the pain. Many times anxiety, depression, they are the very important effects of the pain, and attention. Then the steps in history taking. As I told you, the history taking, the steps what we are talking, that before this history taking, let me just quickly talk about the whole of the clinical evaluation process or whole of the clinical methods. How are we are going to evaluate a patient? As this is one of my favorite term I talk, that a clinician is like a detective. So many of you are fond of detective stories. So somebody has committed a murder and the detective is trying to find out. So our role here is almost similar. That means somebody is having a knee pain and we have to find out what is the cause. So there will be a lot of clues there around us. That clues can be obtained by taking the history. That clues can be taken by examination of the patient and also by the investigations. So basic steps in any clinical branch is your history, clinical examinations, and investigations. In the history, as I told you, in the pain, we are having the general history, specific history. And in the clinical methods, means in the science, the examinations, earlier there was no the systematic ways of examinations. But now it is developed, and you know that these are the few steps. What are those? First is your general examinations. General examination means the examination of the patient as a whole, starting from the pulse, respiration, temperatures, all those things. Then comes is your, so after the history I'm talking, general history, then is the special history, then your examination starts with general examinations. Then is your inspection, then is your palpation, then is your range of movement. So it's basically the musculoskeletal system and the neurologic nervous system together is your pain. So means examination of the patient of pain. So here is your inspection after the general examination, inspection, palpation, range of movement. Range of movement includes both active and the passive range of movement. Then whole neurological system, starting from the higher centers, the sensory, the motor, the reflexes, everything. And then at end, we should be having some specific clinical evaluations. That is the special test. So the special test is not, we are going to suppose the knee, there is a long list of special tests. You need not go for all the long list of special tests. You should be just depending on your earlier history and the examinations, you should be deciding that this special clinical test might be needed. So this is the examination part, physical examination part. Then comes with the investigations. In the investigations, we are having the laboratory investigations, the blood examinations, then is the image. In the image, ultrasound is one of the very, very important part. Apart from the ultrasound, we are having the X-ray, CT scan, the MRI, the PET scan. And another very important step in the hand of the pain physician is your diagnostic intervention. It is not there in the other clinical entity, other clinical branches. Here it is. What is that? When suppose you are examining a patient to the back and you are suspecting it might be facet joint, it might be SI joint, it might be myofascial pain. So what you need to do, you under the image guidance, you just inject local anesthetic in the facet, see the difference. You inject the local anesthetic in the SI joint, see the difference. If the pain is reduced by more than 50%, most likely that is the source of the pain. So this is called diagnostic intervention, and this diagnostic interventions is a very special weapon in the hand of a pain physician. So what are the steps then? History, general history, specific history, then comes examinations, general examinations, inspection, palpation, range of movement, both active and passive, whole neurological examinations, special clinical test, then investigations, blood investigations, image, and at the end, we are having the diagnostic interventions. But before all these things, another things you'll be remembering, the next subsequent classes will be elaborating more, that when you start talking the history, in our mind, we should be remembering the causes. That means, suppose your patient is telling that, sir, I am having knee pain for the last 3 months. As soon as it's telling I'm having the knee pain, you are having the knee pain told by the patient, immediately in your mind you should remembering these are the list of the knee pain, which these are the causes of the list of causes of the knee pain. And also have to remember that these are the red flags, means these are the dangerous diagnosis in the knee pain. So also you have to remember that. And then you start taking the history. Why? Because this, your ultimately what is your aim? Your aim is to find out the diagnosis, the causes. So how to find out? You have to remember the cause. You must be knowing that out of them, this list, somebody should be there. That's why I always tell that the clinician should be a detective. So like, how a detective, what a detective do? It goes to the site of the murder, interrogate all around there, and you find out that this might be the amongst these people, somebody should be the cause. Same way, whenever the patient is talking about I am having knee pain, immediately in your mind should be having the list of the causes of the knee pain, and out of them who are dangerous. Why this is important? Because dangerous diagnosis should be sorted out very quickly, and here the investigation should be done early. And here, the multidisciplinary team is important. So you have to take in your team, there should be having an orthopedic surgeon, sometimes you should be having a neurologist or neurosurgeon. So team should be there so that you are not missing a dangerous diagnosis. So there are certain features to rule out the red flags. So in our subsequent classes, we'll be taking care of each area's red flag is different from other areas. Like red flags in the headache, red flag in the back pain are not listed, it's not the same. So you have to remember the list of red flags also in there, in each areas. So again, what are the steps in clinical evaluation then? So first is your history, but before that, you have to remember the causes of that and red flags. In the history, general history, specific history, and then the other steps, whatever I have to. So now come back to the general history. The general history, first part is your chief complaint. So chief complaints will be just 1 or 2 with the duration. Then comes the history of present illness. History of present illness is the most important. I'll be again elaborating it maximum, and I must be remembering that the history of present illness gives the maximum clues. Maximum clues is obtained from the history of present illness. Then your treatment history, family history, occupational history, personal history, psychological assessment. That is also very important. Psychological assessment should also come from the history. We are not psychiatrists, but certain basic things we have to remember, and we need to know that which patients need an additional psychiatrist consultation. For that, the basic psychological evaluation is also a part of evaluation of the patient. So now let us elaborate the history of present illness. The history of present illness, what is important is your assessment of the quantity of the pain. Quantity or severity or intensity. How much is the pain? And here again it is having the 2 broad types. One is how much a pain is hurting physically, or by WHO ISP's definition, the sensory component. Pain is an unpleasant sensory and emotional experience. So how much is the sensory component is assessed by the unidimensional pain scale. It is assessing only the how much pain is physically hurting. As you already told, pain hurts us in different ways. Pain hurts us physically, that is a sensory component. Pain hurts us emotionally, that is the emotional component. Then the pain has also other aspects, other facets, dimensions. Like when we suffer from pain, our cognitive functions are not do not work properly. Our cognitive functions are deranged. Like cognitive function means if I'm having very severe pain and I have given a complex mathematical calculation, I am not able to do it. If there is an important, the TV show is going on, I won't be able to concentrate on it if I'm having very severe pain. So all these are cognitive functions. So these cognitive functions will be affected by the pain. So the pain has different dimensions. So when we are just assessing the physical dimension, sensory dimension, the scale used to measure that is called the unidimensional pain scale. And when with the pain scale, we are assessing the physical component, we are assessing the emotional component, we are assessing the cognitive functions component, then this is called the multi-dimensional pain scale. I will come to this point in later in detail. Then comes the assessment of the quality of the pain, nature of the pain, whether the pain is nociceptive, nociplastic, neuropathic, mixed. So this can be assessed by again by the different tools. Particularly the assessment of the neuropathic pain is very important, and that helps us in final diagnosis, as well as that helps us to choose the drug to take care of the pain. So suppose somebody is having the neuropathic pain, what drug should we give? We should not give paracetamol. We should not give morphine. What we should give? We should give like trigeminal neuralgia. Shall we give paracetamol? Shall we give diclofenac sodium? And there is no. We are going to give carbamazepine. We can give also the oxcarbazepine. These are drugs. These are not analgesics. So this is by assessment of the by whether the pain is neuropathic or not. So next is your, this is by the assessment of the quality. Then is your other kind of the which helps us in making a diagnosis is your mode of onset, location, where is the pain and how it started, duration, chronicity, frequency. Some kind of pain comes, goes, like trigeminal neuralgia, like cluster headache. So what is the frequency? What are the aggravating and relieving factors? Is there any special character in the pain? Like migraine headache has a throbbing character. So similarly, if there is any special character is there, timing of the pain and the diurnal duration, when does the pain appear? Like in cluster headache, this is also called the alarm clock headache. Every night the pain comes. So what is the timing? Any diurnal variation, like some pain, like inflammatory arthritis pain, comes more in the morning pain and stiffness, and then gradually reduces. So any relation to the posture, like sacroiliac joint pain, if you are sitting, pain will be aggravated. And if there is any radiation and any other associated complaint, right? So for example, pain is related to the weakness, very important. Pain is the tingling sensations. So these also are very important, any associated complaints are there. So this is very, very important. And as I told you at the beginning, to assess the pain, to evaluate the patient suffering from the pain, the history of present illness is the most important area. Now we'll be elaborating it a little bit more each steps. So chief complaint, then history of present illness, the intensity or the quantity of the pain can be assessed by unidimensional pain scale, which assesses only the physical component. Multidimensional scale assesses all components of the pain. Unidimensional pain scale, one is your verbal rating scale. Verbal rating scale means you are asking the patient, tell me whether your pain is mild or moderate or severe or excruciating. So this is your verbal rating scale. Then is your binary scales. Binary scale means tell me whether you have the pain or not. Yes or no. Pain is there or pain is not there. Then comes is your numeric rating scale. Numeric rating scale is the most commonly used. What is the numeric rating scale? You are asking the patient, or even if you can show the some 0 to 10 points and asking the patient, if there is no pain, then it is 0. If there is maximum pain you can imagine is your 10. Now you tell me how is your pain. This is your numeric rating scale. Most of the times we are doing that. What is the difference between the visual order scale? Visual order scale, you are giving a scale and you are asking, put your point here in this scale. That is a visual order scale. But in the numerical rating scale, you are telling the number or showing the number and asking to how much is the pain. Not showing a scale and asking to point on your scale. So it is similar, but not exactly the same. And the facial rating scale is your, so this is your numeric rating scale from 0 to 10 is there. You can ask, it is not any scale you are showing. So this can be even told by you, by your mouth, or you can show the scale and tell, show these numbers and tell how is your pain. Then is your, the facial scale is very important for assessing pain in the children and also those who cannot speak. And this is your VAS. So visual order scale. You are giving a scale and asking, please, on this scale, you just show where is your pain. So this is your, the comparison between this. Verbal rating scale is basically your patient is asking, okay, no pain, mild pain, moderate pain, severe pain, excruciating pain, like that. So visual order scale is patient is asked to point your, in this scale, please point your marking where is your pain. Numerical scale is similar, but here the numbers are there. In the visual analog scale, numbers is not there, but sometimes scale might be having the number. But here the number is important, and patient will be telling, okay, 4 or 5 or like that. And the facial rating scale is your by face. You are trying to understand it. Now, these all pain scales are unidimensional, meaning that we are assessing only the sensory component or physical component. Then comes the multidimensional pain scale. Multidimensional pain scale means we are assessing the other aspects of the pain, emotional component, the cognitive functions, and the most important out of this list is your McGill's pain questionnaire. So in the McGill's pain questionnaire, there are different sets of questions. 10 sets of questions is for the sensory discriminative. That means nociceptive pathway. That means this is going to assess your sensory component or physical component of the pain. So McGill pain questionnaire can assess the physical component by 10 sets of questionnaires. Here the questionnaires are there. Then 5 sets of questions are for the emotional, motivational, affective, reticular, and the limbic structures functions. So this is your, there are 5 sets of questions are there for this assessment. Then one set of question is your to cognitive functions, and 4 sets to describe the other miscellaneous part. So what is important here, that the McGill pain questionnaire by the same tool, you can assess the different component, but again, it's very elaborative, it takes time. You know, majority of the pain clinic, this detail of this is not done. Instead, what can be done, like in our clinic, what we do, we assess the sensory or emotional affective component by using another tool, that is your either THQ9 tool or HADS scale. With that, we try to understand what is the emotional or the motivational affective component. So one very common question, particularly my favorite question, is whether the McGill pain questionnaire can assess the quality of the pain in terms of whether the pain is nociceptive neuropathic. Can it assess that? Answer is no. So the McGill pain questionnaire can assess the sensory, whether the sensory component part, but it cannot, nociceptive pathway, but it cannot tell us whether the pain is neuropathic or nociceptive like that. So remember these things. So it can assess the sensory part, it can assess the quantity of the sensory component, then the emotional component, the cognitive functions, and other miscellaneous. You can go ahead with the detail of that score. Then the assessment of the quality or nature of the pain, whether the pain is nociceptive, whether the pain is neuropathic, particularly whether the pain is neuropathic or not. To assess that, there are different tools, different questionnaires. All these questionnaires are, you know, the history like these things. Some physical examination part is there, but mostly it is the physical aspect. One very important again question: how to assess a neuropathic pain? And there is no specific test like blood pressure instruments or blood sugar. You can tell the patient is diabetic or not, but here, or hypertensive or not. But here we don't have such kind of simple thing. So here, the neuropathic pain can be assessed by the bedside tools. All these tools, what are asking, taking about your bedside tools, and with the history mostly, and little bit of examinations, we can assess the neuropathic pain. But there are a few other things are there. One should remember, that is called the quantitative sensory testing, QST. QST is another, but again, it is a very costly test, normally not done in the routine clinical evaluation. And another is sometimes the nerve biopsy to see the nerves areas in the peripheral nerves. The skin biopsy is done to assess the pain is neuropathic or not. But these two, that means the QST and nerve biopsy, are the other ways to assess neuropathic pain, but mostly the bedside clinical tools are used. These are based on your questionnaires. There is a list. There are the different bedside questionnaires. One is your LANS, one is your NPQ, one is your DN4, one is pain detect, and there is ID pain. So they are the different areas. In our clinic, we normally use this pain detect tool. The reason is this is a free tool. It can be used by anybody without taking the permissions of the original publishers. So that is the reason why this is one of the very important and the most widely used. But the other tools are also important, that also can be used, particularly during the different experimental setup. So this is your LANS, leads assessment of the neuropathic signs and symptoms. And again, here you see there are 5 symptoms. So this is the list of symptoms. pricking, tingling, pins and needles, the needle sensations, electric shock-like sensations. So all these are carrying different marks. Like if somebody is having the pricking, tingling, pins and needles, it will carry 5 marks. The electric shock-like or shooting, it will carry 2 marks. The skin color changes, 5 marks. Pain evoked by the light touch, allodynia. Skin temperature, hot or burning. So these are the symptoms. And the other 2 signs. One is your allodynia, brass allodynia. When you're putting a brass, there is pain, or pinprick. So these are the different, the different the scores. And the score, if it is our total score possibly is your 24. If it is less than 12, then this is unlikely neuropathic, means it is mostly your nociceptive pain. If the score is 12 or more, then it is likely to be neuropathic pain. This is your leads, the leads assessment of the neuropathic symptoms and signs. Then comes is your DN4. So again, the similar kind of things. There are 2 signs, the 3 signs. One is your hyposthesia, anesthesia or hyposthesia. The hyposthesia to the touch and prick, and pain caused or increased by the brassing, that means allodynia. And they are the different symptoms. So out of these 7 symptoms related to the 7 symptoms and 3 signs, that means total 10. If 4 is there, that is your neuropathic pain. So this is easier because we need not remember any scoring system. We just need to remember the 7 symptoms and the 3 signs. And if it is more than 4, then it is the neuropathic pain. And sensitivity and specificity is also very high. Sensitivity is your 83%, specificity is your 90%. Then is your similar NPQ. Then is your ID pain. I'm just skipping these things. You can later read books and read the presentations. This is I am going to elaborate more because mostly this is used, and again, as I told you, this is a free tool. So here the signs, the symptoms are 7 symptoms: the burning, tingling, the light touch producing pain or not, sudden pain attacks like electric shock, application of the heat or cold is producing pain, numbness, and slight pressure triggers the pain. So these 7 symptoms each can produce score from 0 to 5. That means burning sensation, if it is not there, 0. Mild, it might be 1. And very severe, excruciating, it might be 4 or 5. So in that way, tingling, it can be 0 to 10. Each of these symptoms can be somewhere between the 0 to 10. And that, the 7 into 5, that means 37. Then there is the 4 kinds of pain fluctuations. And each again, the carries some marks, and the radiation, whether the pain is having the radiation or not, that carries 1 mark. So total, if the score is more than or is equal to 19, more than 18 or is equal to 19 or not, then it is your neuropathic pain. If it is less than 12, then it is unlikely neuropathic pain, mostly it is nociceptive pain. And if it is between the 13 to 18, then it is a mixed nociceptive plus neuropathic pain. So again, the sensitivity specificity is like this, and you have to remember that these kind of tools are very important to understand what kind of analgesics or co-analgesics we are going to prescribe to control the pain. Another thing is very much helpful to assess the neuropathic pain. We can understand whether the patient is having the nerve damage or not, so that we can identify the where is the tissue damage, and accordingly we can plan our management. So this is your assessment of this is your pain data tool. You can download it from the internet. As I told you, this is free, and you can use it in your clinic. So this is your assessment of the quality. So what we told in the history of present illness, first was assessment of the quantity or amount of the pain or intensity of the pain, and that can be assessed by unidimensional pain scale or multidimensional pain scale. Next step was assessment of the quality, whether the pain is neuropathic or not. Then what are the other areas? Onset, mode of onset and location, how it is started, whether it is the gradual or whether it is the slow onset. Then what are the aggravating factors, relieving factors? then your special character, whether it is there or not, and timing of the pain, then your relation with the posture, whether it is increasing or relieving with the sitting or standing or lying down or walking. So all these are very important when we're discussing about the different particular areas of pain, like knee pain, shoulder pain, headache, all those things are important. The site of the pain and radiation and referred. So this is one very important, many times this has been asked by the participants, that what is the meaning of radiation, what is the meaning of referred. So basically the source of the pain, starting point of the pain is one, and it is going to the distal areas. So it can be either called radiation or can be called referred. So most of the time we are using this term, two term interchangeably, but radiation pain means it is the area of the same nerve distribution. Mostly radiation is talked about here, the area when there's some nerve interruptant or root interruptant is there, and the pain will be along that area of the which of the nerve is supplying. But again, it is not strictly applied to that one. Referred pain means it is not continuous. It is somewhere the pain is there, and somewhere the pain is like myocardial pain, infection pain is referred in the chin, in the fingers. So that is referred, and not the whole of the area is having the is painful. But again, as I told you, radiation pain and the referred pain, clinically, it is very difficult to distinguish whether it is really a radiation or whether it is referred. And most of the times, we are using these two terms interchangeably. Means any pain which is having a source and going distally can be either called a radiation pain or can be called a referred pain. The associated complaints, whether the patient is having the nausea, whether the patient is having the fever, weakness, all this kind of important. Then your past medical history, again very, very important, and it gives a lot of clues. So any history of surgery, trauma, comorbidity, what kind of medicine has been used, whether the medicine is giving relief or not. Suppose somebody is having a ankylosing spondylitis, the patient will be telling that, okay, as soon as I am taking the non-steroidal anti-inflammatory drug, I am having very good relief. So this can be very important clue to make a diagnosis. Personal history, again, the bladder bowel habit is very important in particular areas. How is the sleep? Again, sometimes it is important to understand some of the diagnoses, the history of smoking, alcohol, the family history, having whether the family members having the similar kind of the disease, occupational histories. So all these important. Now the important area what we are discussing about the red flag or the warning signals. As I told you, the red flag and the warning signals are different in the different kind of pain, but there is a common list. So this is almost applicable everywhere. So what are those? One is if the pain is after a major trauma, after an accident, or if you suspect some fracture, or if you are suspecting that there is a tumor, patient has a history of any cancer, or if you are suspecting infection, like patient is having fever. So this kind of history is always a red flag. Wherever is the pain, whether the pain is in the headache, whether the pain is in the shoulder. So this kind of history, trauma, tumor, fracture, or the infection, we should be always categorize that kind of pain as a red flag. If the patient is unconscious or the patient is having the loss of vision, if there is a motor weakness, or if the sensory deficits, numbness is gradually progressing, if there is a loss of bladder and bowel control, particularly if there is a retention of the urine, if there is a sudden onset of the pain which is rapidly progressing and not responding by analgesics. So these are the list of the red flag, almost common in all areas. Apart from that, there are some other red flag specific to that particular kind of pain. Then comes your psychological assessment. Again, as I told you, the psychological assessment should also be done as a part of the history taking in a patient suffering from pain. We are not psychiatrists, but at least we should be having some kind of screening tool. Like as I told, in our clinic, we use the PHQ-9, but there are a few other kind of things. PHQ-9 again is it is a free tool, anybody can use it. So that is the reason why, important reason that we are, it is a little bit of elaborative, but again, all these are basically questionnaires. So these are the questionnaires for the PHQ-9, and all these are having the different scores. If symptoms are not at all, then 0. If several days but less than half of a month, then it is 1. More than half of a month, then is 0. That means less than 15 days, it is your more than 15 days, and daily, then it is 3. And the other questionnaires: little interest or pleasure in doing things, feeling down, depressed or hopeless, trouble falling or staying asleep, or sleeping is too much. So either of that is important, whether sleeping is too much or not at all able to sleep, feeling tired, having little energy, poor appetite or overeating, either of that, feeling bad about yourself that you are a failure, or have let yourself or your family down, trouble in concentrating on things, moving or speaking slowly or slow restlessly, so slowly or so restlessly, and suicidal thoughts. So all these things are having the marks. And again, the maximum mark is your 27. 9 points are there. 3 into 9 is the 27. 1 to 4 is your the minimal depression or no depression. The 5 to 9 indicates mild depression. 10 to 14 indicates is your moderate depression. In that way, you can think when the patient is having the the more than moderate depressions, the severe depression, then definitely you should be taking help of your psychiatrist. But if it is a mild depression, if it is a moderate depression, up to 14, you can take care. More than that, always take help of your psychiatrist friend. This is your hospital anxiety and depression scale. This is also important, so you can use this one also. And this is the history sheet what we are using in our clinic. So again, here we are having the personal letters, the name, age. Always remember that the prescription must be having some at least minimum personal by which you can identify that person. So then is the symptoms and how many days. Then is your how much is the pain, and it should be from the maximum pain, average pain, and the pain present at that particular time. Then this part is the pain detect tool, and then there are aggravating factor, relieving factors, diurnal variation, medical history, family history, personal history, occupational history, psychological PHQ-9 score. Again, this is the PHQ-9 tables. And then is the clinical science, inspection, palpation, range of movements. That's just important, positive or negative findings, neurological examinations, special clinical test. So this is your science. And then is your investigations. Investigations, there are certain bedside clinical tools. Apart from the tools used for the neuropathic pain, there are certain other tools are there which can be used, particularly the fibromyalgia, DCR criteria tools. Then you laboratory investigations, image, and finally we are making a pharmaceutical diagnosis. So this is how we should go, and this kind of the history sheets are important. And if you are elaborately filling this form, as I told you, any new patient, it should take at least half an hour to complete the history, and maximum clues in a patient suffering from pain should come from the history, particularly the history of present illness. Okay, thank you. And okay, these two slides are also important, that when the patient should be treated by us, when we should refer this patient to a orthopedic surgeon or the neurosurgeon. So, and when the very important part is when the pain is, there is red flag, we should be always consulting our friends. When the pain is your mild, then again the role of interventions are not there. You should be treating this patient conservatively. And if the pain is the more than a month, no red flag, more than mild, then you can think of the interventions. These are particularly important for the interventional pain physicians like me. And going to refer these patients, if the patient is having red flag, or if the patient is not relieved by the interventions. So the other patients, they should be referred to our surgical friends, means the neurosurgeons or. But this is the general rule. Case to case is very important. Suppose you are treating a patient with a fibromyalgia, and your medical management has failed. You have done some interventions. You have done the intravenous desensitization. Everything fails. Should you refer this patient to a surgeon? There is, I give this example that if it is asked that what is the surgical treatment of malaria? Is there any surgical treatment for the malaria? Definitely not. So same way that not all patient needs interventions, not all patients need surgery. So it is the specific diagnosis, specific evaluation that ultimately helps us to determine. What I told is a general rule, but it is not applicable for each and every patient. So thank you very much. And I'm stopping here, and you can ask the questions regarding this history taking.